Good to get started. Good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, and then I'll introduce tonight's speakers. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and we will have a Q&A portion at the end of the presentation to address these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Etai Goldenberg of Urology of St. Louis. And we will also, at the end of the presentation, hear from Cliff Pollock, who is a patient champion who can share his journey that he's dealt with erectile dysfunction. And now I'll hand it off to Dr. Goldenberg to get it started. Thank you.
Hi, good evening, everyone. Thank you for tuning in. Thank you for the introduction. Work here we go. All right, this is a discussion about men's health. I'm focusing primarily on male stress incontinence and erectile dysfunction. Please feel free to ask questions as we go through it. So this is me, Etai Goldenberg. I'm a urologist here at Urology of St. Louis. We are the largest private practice urology group in the St. Louis metro area. We have offices on both sides of the river, in Missouri and in Illinois. And I primarily go to our offices at the Walker Medical Building in St. Louis and Anderson Hospital in Illinois. But additionally, we do have some other partners that cover 11 hospitals in the region. I did my training at my medical training at Wayne State University. Then I came to St. Louis and did my urology training at Washington University. After that, I went to New York, where I learned a specialty care in sexual health and infertility treatments. And then we came back here with my family and been in practice here at Urology of St. Louis for 10 years. The goal of my practice is really to take care of men with sexual health issues, urinary continence issues, and fertility issues. And really that's the sole thing I really do with my practice at this point. And I really enjoy taking care of men that have these issues. So please stop me as we go through the presentation. I would love to talk and answer questions here and go through these slides. So the way I have this talk set up is the first part we'll be talking about stress incontinence, and the second half we'll talk about erectile dysfunction. I'll stop for questions halfway through. So understanding what male stress incontinence is and what are your options. So to start with, what is stress incontinence? Who has it, what it is, and what are the causes? So do you think about a process of urinary leakage? I usually like to focus on what should happen normally first. So if you think about the anatomy, the kidneys sit up high, not pictured here on the screen. And then as you come down, the urine then gets made and deposited into the bladder. The bladder is a muscular organ that can stretch in order to hold the urine. And so what happens is the bladder will stretch and hold the urine, and it's blocked up here at the bottom by two spots. Inside the prostate is the internal sphincter, which is a muscular unit that stops urine from leaking. And outside of it is this external sphincter that stops the urine from leaking when you don't want it to. Then what happens is when a person chooses to urinate, two things happen. The bladder squeezes, and so it pushes with that muscle, pushes the urine down into the urethral tube. And there's relaxation here of the muscles inside the urethra in the prostate and in the external sphincter to relax to allow that urethra to be open for the urine to pass. And then when you're done peeing, these muscles tighten back up again. Your body does this naturally. What happens is when a man has an injury or a problem with the sphincters, they can have what's called stress incontinence. So when a man will cough or sneeze or lift something heavy, they will have what this stress incontinence where the urine leaks past those areas. There are also other types of incontinence. There's a type of incontinence called urge incontinence. That's when the bladder, the muscle that's supposed to hold the urine, is not as stable as it's supposed to be. And it squeezes when you don't want it to. Sometimes it means that it squeezes so hard that it pushes the urine out and the urine leaks. Sometimes what happens is it just really is so sensitive that when you have to go, you have this feeling of I gotta go, and I can't hold it. That's what we call urge incontinence. And there are many men that have both these issues, a combination of stress incontinence with urge incontinence. So focusing on stress incontinence, the question is who has that problem? Again, stress incontinence is when your bladder is holding urine and there's increased abdominal pressure from coughing, sneezing, heavy lifting, and that pressure on the belly pushes the urine past the sphincter mechanism or the muscle that's supposed to be keeping the urine inside. The most common reason that a man develops stress incontinence is because of damage to that sphincter. That's done most commonly because of prostate surgery, usually a radical prostatectomy when the prostate's removed for prostate cancer. In addition, when there's treatments for a large prostate, like a TURP or a HOLEP or different surgical procedures for enlarged prostate, also radiation therapy can affect that muscle unit. In general, when a man has their prostate removed, something between 9 and 16. So I usually tell my patients 10% of men that have their prostate removed for cancer do develop stress incontinence and persistent stress incontinence. And as we talk about that more, it's very common for a man to have some leakage after their prostate's removed. Why does that happen? So if you think about the anatomy here, the bladder sits here. This is kind of the other way, where the bladder sits here, the prostate sits here, and the urethra sits here. When a man has their prostate removed, there's an incision made here at the bladder neck where the prostate connects to the bladder. There's an incision made here where the prostate meets the urethra. This is done most commonly in what's called the nerve-sparing approach, where these nerves, this neurovascular bundle, is freed off the prostate, sparing those nerves and preventing their injury. And then, if you see here, the urethra is brought back into the bladder. When this happens, you lose the muscle that was the internal sphincter, the muscle that was inside the prostate, and you're reliant only on the external sphincter, the sphincter mechanism that was here in the urethral portion. And so what happens is after a prostate's removed, most men do have some leakage when they cough or sneeze or lift something heavy in the short term. However, that usually does improve over that first year. And like I mentioned before, after a year, about 10% of guys have bothersome incontinence that needs an intervention. However, given the high number of prostatectomies that are performed in the United States each year, over 180,000, that 10% still is a very large portion of men that are bothered by stress incontinence annually. So what are the options? So really in the short term, in that first year after therapy, we really focus on coping mechanisms like pads or diapers or things to collect the urine. We work on pelvic floor physical therapy and in Kegel exercises. So after man's prostate is removed, we really recommend a focus on strengthening that muscle that's left behind. That can be done by Kegel exercises, which are muscle exercises that are also performed to help women after childbirth strengthen those same muscles that prevent leakage. You want to do is kind of help strengthen that pelvic floor to allow for the muscle to work better. There are studies that show that men that do pelvic floor physical therapy, meaning doing those Kegel exercises or other similar exercises together with a physical therapist, do a better job strengthening those muscles. Also, behavioral modifications. If you say, I usually leak when I go and play tennis, maybe if you go empty your bladder before you go do that physical activity, if there's less urine in your bladder, there's less chance at leakage. Also, reducing caffeinated beverages and carbonated beverages and lots of fluids before exertion would also help. When a man has persistent bothersome urinary leakage with this stress incontinence after a year, we really do focus on surgical options for a man, including a male sling and artificial sphincter. These are two different surgical procedures, both offered by Boston Scientific, which help a man that has stress incontinence to get better. A male sling is designed to help support the muscle that's left over. So if a man has some muscle left behind, so usually a man that has mild to moderate urinary incontinence after their prostate surgery, may be a candidate for the sling. This is a piece of mesh that goes under the urethra and just helps support that muscle in a better position, allowing it to function better. An artificial urinary sphincter, in my mind, is really best for a man that has severe incontinence, a man that's had a sling and it's failed, or a man that has moderate or heavy incontinence after a prostatectomy as well as radiation therapy. But this is an option really for a man with all types of incontinence. This is a 3-part device, which I'll show in a little more detail in a moment, with a cuff, a control pump, and a pressure regulating balloon, allowing a man to really have an artificial cuff that really regains that muscle that you used to have before their prostate was removed. So with a little bit more detail here, how does the sling work? A sling has been around for over 10 years. If you see here in the picture, this blue line represents where the external sphincter, the muscle that was left behind, is present. The mesh is placed here against the urethra and then brought up through the obturator canal or through the hips. And then as it's pulled into position, as you see here, that outside part of the urethra is folded over itself to allow for a stronger muscle unit, and really just giving extra support to your natural muscle. This is really ideal for a man with what I consider mild to moderate incontinence, which is 4 pads or less per day. And in the right man who has, really has that mild to moderate incontinence, if we put a sling in, there's a really high satisfaction rate. Over 90% of patients are happy. And usually my goal with this procedure is to get a man to 1 light pad or less per day. This can be done as an outpatient procedure, or some of my patients will stay overnight. And then once the device is in place, it's not interactive. It really does reposition that urethra and reposition that muscle so everything functions well on its own. Another option is the artificial urinary sphincter. This is a therapy that's really been out for over 40 years. It is the gold standard for stress incontinence. How does it work? There's this cuff. The cuff really is in a very similar position where the natural muscle used to be. The cuff, once it's activated, is closed tight like this. And then you squeeze the control pump and it opens up the urethra and allowing the urine to come through. By doing this, there's a constant pressure right there at the urethra, stopping the urine from leaking until you activate the pump. So every time you want to urinate, you squeeze the pump. The urine then is able to flow, and then over the course of 2 to 3 minutes afterwards, the cuff then refills and restores your continence. If you see here on this video, which I think is helpful to see what's going on, the cuff sits here around the urethra, compressed all the time. As you squeeze the pump, the cuff opens, the urine then comes through. And then after you're done urinating, the device reactivates, and the cuff then closes again, allowing for you to be dry. There's a very high satisfaction rate with an artificial urinary sphincter, over 90% of men. This really is for patients that have severe incontinence, again, or men that have failed the other therapies. It mimics the healthy sphincter muscle. In my practice, men that are leaking heavily, 6-8 diapers in a day, and we put an artificial urinary sphincter and they leak 1 pad or less per day, are really the happiest patients in my entire practice. These are surgical procedures. Both a sling and an artificial sphincter do carry risk with either surgery. Because we are doing a procedure to help with continence, there's a possibility that a man will develop urinary retention, so the urine doesn't leak, it doesn't drain at all, and catheters or suprapubic tubes are needed. There is a small risk of infection with either device. The sling is a foreign body, and there's a risk of infection or irritation. The artificial sphincter, again, is a foreign body inside, and it's a piece of machinery that usually does last for a long period of time, but most commonly around 10 years or so, the device may malfunction or break and would need to be replaced. Insurance does cover both of these surgeries, but before we would do a surgery, we would verify your insurance coverage to make sure that you know what your out-of-pocket cost would be. I know I went through this rather quickly, but the idea is to really explain that a man that has stress incontinence after prostate surgery, that there are options, especially surgical options. And if this is something that is bothersome to you, you can start by going to fixincontinence.com. I'm happy to see you in the office to discuss further and really get the ball rolling on the workup that'd be necessary to see if these surgical procedures are an option for you. So in summary, if you are interested, there's really are a variety of treatments options, including a sling and an artificial urinary sphincter, which should hopefully offer a permanent solution for male stress incontinence after prostate surgery. Start by talking to your urologist or a prosthetic urologist like myself in order to get the ball rolling with the intervention. Are there questions, Annie? And then before I jump into erectile dysfunction? Did I lose you?
Okay, any questions? I've seen one come through. How long should I wait to consider one of these incontinence options?
So for the most part, when a man has stress incontinence after prostate surgery, there's really uniformly everyone has some leakage immediately after the catheter is out. And we recommend that patients do the Kegel exercises and pelvic floor strengthening and allowed to improve their incontinence. And so I usually think that it's best to consider a surgery after a year. However, if a patient says, you know, I was leaking 4 pads a day and now I'm at 2 pads a day and it's been a year, should I do surgery? And they're still getting better week to week and month to month. I usually let them keep doing whatever therapy they're doing to try to continue improvement. If they keep improving, then we just wait a little bit longer and then intervene. I'd rather wait a longer and intervene when it's necessary as opposed to intervening too early. But usually I wait about a year from the surgery and then evaluate then, and then kind of see the trajectory of what the incontinence is doing. Does that answer the question?
Yes, absolutely. We had another question saying that, or it's more a statement, but incontinence can only occurs at night while asleep. So what would you say to that?
So that's most likely not stress incontinence. When we see patients with the stress incontinence, it's most common. The thing I hear from patients most is that they have the opposite, where they have leakage during the day because they're active and they're on their feet and they're coughing and moving. And then at nighttime, they're not active, they're just laying in bed and so don't have leakage. So most likely, if the leakage is only at night, this is either more of an urge incontinence or could just be different types of other medical issues like reabsorption of fluids from the lower extremities after standing up all day and laying supine. Probably worth doing a bladder diary and seeing kind of intake and things like that. Definitely something we can help take care of, but probably not an ideal patient for these types of interventions.
He did add that this was after prostate surgery.
Got it. Yeah, it probably needs a little bit more workup because it's usually the other way around when it's stress incontinence. But definitely someone we can see here and get the ball rolling.
And the original person who asked a question said that they were the one that asked, should I wait to consider, how long should I wait to consider one of these options? And they said, I've improved, but can't Kegel all the time. And they had surgery 1 month ago.
Oh, a month ago? Yes. I would wait, give your body time to heal up. If it's only been a month, definitely do the Kegels, as instructed by the person that did your prostate surgery. But the hope would be over the course of the next few months, and then definitely by 6 and 12 months out, if you're only leaking at 2 pads, hopefully you won't need any of these other interventions.
Wonderful. I think that's all the questions for now.
Perfect. All right. Well, if that's the case, I'm going to change gears slightly here and talk about erectile function and erectile dysfunction and talk about the treatments options for that. Okay, so erectile dysfunction or ED, what is it, who has it, and what are the causes? So again, when I think about what erectile dysfunction is, it's really the inability of a man to achieve or maintain an erection that's firm enough for them to have sexual activity or sexual intercourse. It's really common. About 1 in 5 Americans over the age of 20, and then more than half of American men over the age of 40 have some degree of erectile dysfunction. So overall, that affects about 39 million American men. In basic, when I think about the normal erectile function, how does it work? So to start with, it starts, what's not pictured here on the slide is, it starts in the man's brain. they have to be stimulated. So having the right amount of testosterone helps a man have the sex drive and desire and libido in order to just, want sexual activity. Stress, anxiety, things like that are, can really fight against that desire. And once that signaling leaves your brain and go down to the penis, you have to have normal blood vessels and normal nerves, then stimulate the penis. Once that signaling gets to the penis in the flaccid state here, I think of the penis as really the three tubes here. There's the pink tube here that's illustrated as the erectile bodies. You can't tell on this picture, but it's really two tubes side by side. These are two tubes or corporal bodies that have many blood vessels in them. And then underneath is the urethra. That's what we were talking about before. That's where you pee through. What happens is when the flaccid state is stimulated, the artery or the blood that comes into the penis, into this corporal body. Lots of blood comes in, and then this tube then fills with blood. There are veins that then collapse and really hold the blood inside until a man completes sexual activity. So as I mentioned before, this is a phenomenon to get an erection that's really requires healthy blood vessels. And for that reason, the reason that men have erectile dysfunction is commonly vascular problems. So about 40% of guys with erectile dysfunction have vascular blood flow issues, and another 30% have diabetes. Diabetes affects blood vessels. It also affects the nerves that go down to the penis. In addition, different medication, often blood pressure medicine, can affect blood flow and therefore affect a man's ability to get an erection. Other issues like prostate cancer treatment are really common, or pelvic injuries. So I'm going to talk a little bit more about kind of each of these really common reasons that men in America will have erectile dysfunction. To start with is diabetes. So diabetes is very common. Over 15 million men in America have diabetes, and men with diabetes, erectile dysfunction usually occurs much earlier than men without diabetes, about 10 to 15 years earlier. And then when they get erectile dysfunction, these men are harder to treat because oftentimes pills that are given for erectile dysfunction don't work as well as the general population. About 1 in 2 men, so half of men that have diabetes say it causes sexual issues. And there are men that I see in my office often that come into the office for erectile dysfunction, and I discover that they have diabetes, and that's their underlying issue. Factors that really affect your degree of erectile dysfunction are your age. Like I mentioned before, half of men over 40 do have erectile dysfunction. If you compound that with diabetes, that can often make your erectile dysfunction kick in earlier. Diabetes control, presence of other types of diabetes complications, as well as if you have heart disease on top of your diabetes, are risk factors for having worsened erectile dysfunction in a diabetic man. Erectile dysfunction with heart disease, like I mentioned, to get an erection is dependent on good blood flow into the penis. And if you think about that artery I mentioned that opens up to allow the blood to flow into the penis, that artery is about 1 to 2 millimeters in size. Compare that to the coronary artery or the artery inside the heart, that's about 3 to 4 millimeters in size. So any man that has a history of heart disease or heart attack or heart stents, that means that they had blockage of this artery, the coronary artery. And by definition, if they are going to have risk factors for having heart disease and blocking this artery, they almost for sure have some blockage of that penile artery. How can cardiovascular disease be reduced? Diet, exercise, weight loss, reducing stress, quitting smoking are all things that can help reduce heart disease, and reduce heart disease, helping your erections. As I mentioned at the beginning, low testosterone is really so testosterone in general is important for having libido and sex drive and desire. If a man has low testosterone, they often will have the opposite. They have symptoms of lethargy, feeling tired, and then not having as strong of a desire for erections or having erectile dysfunction. The men that often have low testosterone are really similar to the men that we're talking about also that have erectile dysfunction for other reasons. About 4 in 10 of men over the age of 45. And they also corresponds to have a low testosterone in men who are overweight, men who have diabetes, men who have high cholesterol. All risk factors for heart disease and diabetes do also give you risk factors for having low testosterone. So as I mentioned, if you have a low testosterone, testosterone is the hormone that's made from the testicles that helps with the sex drive and desire. Oftentimes, if you have a low testosterone, that's a blood test that's performed in your doctor's office. You have to have 2 blood tests below a level of 300 nanograms per deciliter to be considered low in your testosterone. And oftentimes these men will feel tired and run down, fatigued, and have less sexual desire. The nice thing is there's lots of therapies available to help a man who has low testosterone get back into the normal testosterone range. Those include pills that can help either boost your own production of testosterone or give you testosterone, or other therapies that are what we call testosterone replacement therapy. These are either gels, injections, patches, or pellets, or subcutaneous injections that give a man testosterone and getting their level to the normal range. Erectile dysfunction and prostate cancer. This picture should look familiar. This is the same picture I showed when we talked about urinary continence. And it shows here, again, that when a man has their prostate removed for cancer, an incision is made here, separating the prostate from the bladder neck and from the urethra. And then we peel this neurovascular bundle off to preserve it. This neurovascular bundle is the important nerves that bring that signaling that you started in your brain to get down to the penis. If there's injury to this neurovascular bundle, that signal can't get down to the penis, and that often causes erectile dysfunction. Now, in many men, what happens is that's a temporary phenomenon where those nerves are moved and they pause for a little bit, but then do restore. However, there is a subset of men, and it's about half of men, that after their prostate is removed, they don't regain their erectile function. In addition, some men with prostate cancer not only have their prostate removed, have radiation therapy, or some men have radiation therapy alone. And those things together often increase the risk of having ED after your prostate cancer therapy. Erectile dysfunction and Peyronie's disease. So Peyronie's disease is a separate process than erectile dysfunction, but it's also very common for men to have both of these phenomena. Peyronie's disease is scar tissue or plaque that forms in that corporal body. Like I said, that tube that helps you get an erection gets this inelastic plaque. So what happens is when a man gets an erection with Peyronie's disease, all the penis stretches except for the Peyronie's plaque. And then as that occurs, you get curvature in the direction of where the plaque is located. Having this curvature often can cause difficulty with penetration, pain with sexual activity for the patient, or pain with sexual activity for their partner. There are many therapies that are available for Peyronie's disease, the most common of which is either different types of traction therapy or stretching therapy, or there's only one FDA-approved therapeutic option, that's Xiaflex. Xiaflex is an injection into the plaque itself to help break the plaque down, or surgical intervention. That's either putting plication sutures or shortening the opposite side of the penis in order to straighten it out, removing or cutting into the plaque, or really commonly we'll do a penile implant, which I'll talk a bit more in detail, because this is a treatment that's available for men with either severe Peyronie's disease or severe erectile dysfunction, or if you have both of those issues. So really, what's available for a man that has erectile dysfunction because of any of those things I just described, or for some of the issues I haven't described in more detail? It's really important to start the conversation. Hopefully, coming here and listening to this webinar is step one of getting therapy. But I do think that you don't need to jump to see someone like me, a prosthetic urologist. I think that nowadays, family care practitioners, general practitioners, primary care physicians do feel really comfortable beginning the workup for a man with erectile dysfunction. So start to talk to them about your other medical issues like your diabetes or high blood pressure or high cholesterol, and to see that if you can manage those best, and which will hopefully help your erections. If you continue to have issues, or if you don't feel comfortable talking to your primary, starting with going to a urologist, or going to a prosthetic urologist like myself and a few others in the St. Louis community who really focus on doing surgical interventions for erection issues. So the treatment options, which I'll cover here today, are oral therapy or pills, wave therapy, injections, suppositories, vacuum erection devices, and then a penile implant. So oral therapy or pills really have our first line therapy for most men that have erectile dysfunction. The way they work is these are what are called PDE5 inhibitors. Most common ones are Viagra and Cialis, or their generic formulations. These are taken before sexual activity to allow the blood vessels in the penis to be more sensitive. If you take a medicine like this and don't engage in sexual activity, usually nothing happens. But if you engage in sexual activity or you're stimulated after you're taking this medicine, and most important to take the medications, especially Viagra and Levitra, if you take them on an empty stomach, they work much better. They don't work as well if you have alcohol in your system. But if you do that and you take this medicine, those blood vessels become more sensitive and hopefully allow for a stronger erection. About 70% of guys have success with it. And a little bit, like I mentioned before, a little less likely for diabetic men to have success with pills. There are potential side effects of taking these pills. Headaches, stuffy nose, and upset stomach are the most common. Sometimes if you have side effects from one medicine, we'll switch to another. And it really depends on which some men do better with one versus the other. There are some men that can't take these medicines, most commonly men that are using nitrates or nitroglycerin for chest pain. Another therapy that I want to mention is low intensity shockwave therapy. Now, this is a non-FDA approved option. However, there's been more studies recently in the last 3 to 5 years that have shown this to be a safe option for men to receive. This is a therapy where these small pulse waves go to the penis, allow irritation to the blood vessels that are there, and causing we call it neovascularization, or new blood vessels to form into the penis, and can do some repair of the blood vessels that are there that are damaged. In my experience, about 25 to 50% improvement of erectile function for men that have this therapy done. It's really best with guys that have erectile dysfunction because of poor blood flow. So the patients with high blood pressure, high cholesterol, heart disease, that blood doesn't flow into the penis so well. Hopefully this therapy can help improve those blood vessels. In my experience, men with neurogenic problems, so guys that have erectile dysfunction because their prostate was removed or because of diabetes, tend not to do as well with low intensity shockwave therapy. A vacuum device is a cylinder that goes over the penis and pulls blood inside. Once the blood is pulled inside, then you apply this ring to the base of the penis that maintains the blood in the penis. About 70% of guys have some degree of satisfaction with it. However, there are men that stop using the vacuum device because it can cause some bruising, some discomfort, and change in sensation in the penis that really they don't enjoy, as well as the lack of spontaneity that's required because you have to apply the device before sexual activity. Urethral suppositories are, I'll admit, really not that commonly used, mostly because of cost and a lack of spontaneity. But this is a small device that needs to be refrigerated prior to use. A small pellet is deposited into the urethra and then absorbed into the body. Once it's absorbed, the penis picks up the medication and then allows for erection, usually within 5 to 10 minutes after it's deposited, and allows for an erection to occur. There is a risk of lightheadedness and dizziness. So the first time we tried this medicine, I usually do it in my office to make sure a man doesn't have a drop in their blood pressure. And there can be some urethral discomforts and pain in the penis from the suppository. More commonly, I'll teach men how to do self-injections. So self-injections or intracavernosal injection therapy is something that a man can give himself this tiny injection into the side of the penis about 5 minutes before sexual activity. This is a lot more potent than use of pills, mostly because the medication is directed right into the penis as opposed to taken by mouth and really going through your entire body. Excuse me. The injection is performed. Most men within 5 to 10 minutes get an erection, and the goal is to last about half an hour to 45 minutes. In my experience, more than 60% of these men do have a good response and tend to be happy with the use. But there is some risk because it's very potent. There's a risk of a painful erection or a prolonged erection that can occur. This is something called a priapism. And so for that reason, just like the suppositories, usually the first injection we'll do here in the office and monitor you to make sure that you have a reasonable response to ensure that this is something you'd like to continue longer term. And finally, I want to talk about a penile implant. So a penile implant is a permanent change to your body. What we do is we replace the cylinders in the penis with cylinders that are normally filled with saline or salt water. This is controlled by a pump that sits inside the scrotum and a reservoir that's in the lower abdomen. When a man wants to have sexual activity, they squeeze the pump, and what it does is it shifts fluid from the reservoir into the cylinders. And when you've completed sexual activity, you press a release button, and then the erection goes away. It is a highly satisfactory procedure. Over 90% of guys are happy they had it done. But it is a surgical intervention. There is risk, including infection, bleeding, or injury, or possibility that you don't like the device. And there's a risk that the device works great, but then does have to have a repeat operation. The average device lasts around 10 to 15 years. The most common implant we put in is this AMS 700, which has the 3 pieces as shown here. But there are other simpler devices. An Amicor device is a 2-piece device without a reservoir in the abdomen, and as well as the concealed spectra or malleable device, which are bendable rods with no pump component. The AMS 700, like I said, is the most common device, which consists of the flat cylinder or a circular cylinder. The flat one is the one that I tend to do most. The pump that sits inside the scrotum and the 2 cylinders. The device is coated in antibiotics, so it reduces the risk of infection significantly. So when the device is implanted, it's already pre-coated and covered in antibiotics, really allowing for the best reduction of infection in conjunction with the prep that we do beforehand, as well as the oral and IV antibiotics that are given for this procedure. So they say a picture's 1,000 words. So if you look here, here is the pump inside the scrotum. The fluid is being shifted from the reservoir into the cylinders, allowing for an erection that you can maintain for as long as you desire. Then you press the release button. After you press the release button, the fluid should shift back into the reservoir. Sometimes you need to give the penis a squeeze in order to allow full detumescence to occur. Detumescence to occur. And then if you look here, Dr. Cartman was really nice to share one of his patients. So here in a real person, you can see he's pulling the pump up to the scrotum. Squeezing the pump is allowing fluid to shift into the cylinders in the penis. You can see as you continue to squeeze, you're shifting more fluid into the cylinders. The device is very concealed. You can't tell it's there, and does look like a natural erection. And then when you want the erection to go away, you can see you pull the pump up to the skin. You can identify the release button, as you can see right there under his index finger. You push the button. It opens the valve back up, and the fluid does then shift back into the reservoir. And then in order to completely get the device to empty, if you squeeze the penis, which I'll do here in a second, the rest of the fluid then shifts back into the reservoir. And you can see at rest, it's very concealed inside the body. So satisfaction rate with the penile implant is very high. Well over 90% of patients and their partners are satisfied with the surgery. Like I mentioned before, there is risk like any surgery. Because this is an implanted device inside the body, it carries a few different risks than other surgeries. Because that device is implanted inside the body, there is this risk of infection. And that's why using a coated device and giving preoperative oral and IV antibiotics helps reduce the risk of infection. And there's a risk of mechanical failure. Also, the procedure is done under anesthesia, so your heart and your lungs have to be healthy enough in order to undergo a surgery. It's designed to be a permanent solution and it's spontaneous. It's completely contained inside the body and does have a significant experience. Over 500,000 patients have had a penile implant placed. A penile implant is often covered by insurance. Before we would do a surgery, we verify your insurance coverage to make sure that this is something that either covered for you, or if it's not covered completely, that you know what your out-of-pocket cost would be. Boston Scientific does a really good job of helping us to make sure that we know what your cost would be, so you don't have any surprises. In summary, erectile dysfunction is very common. Like I mentioned, over half of men that are over age 40 have ED, and so there really is not one right answer for every patient. That's why I think it's important to kind of know what your options are and really choose what option is best for you and best for your partner. If you are interested in thinking about this more, I recommend you go to edcure.org, where you can get more information online. I'm happy to see patients in the office, or maybe start by talking to your primary care doctor or your current urologist and asking them if some of these other therapies I mentioned are right for you. How am I doing on time? I think next up, I'm going to have Cliff talk about his experience and then answer questions. Does that sound right, Annie?
Yep, that sounds perfect.
Perfect.
Well, good evening, everyone. What you're going to hear basically is the story of what journey I and my wife took from the time I had prostate surgery through having erectile dysfunction and then not having erectile dysfunction. 19 years ago, I was diagnosed with prostate cancer. And even though it was a very small spot, I decided to have it removed. After I had it removed, I went back to my regular doctor, and he did put me on Viagra. Unfortunately, I was one of those people who acted very negatively to the Viagra. I got terrible, terrible headaches, and they switched me to Levitra, and they switched me to Cialis. Every time didn't matter which one I took, I always had a headache and always was laying in bed telling my wife, not tonight. So after about, I would say, 8 months of that, I did try the external vacuum pump. And I will say it does work. There are a few things about it that are very uninteresting. Number one, it is totally not spontaneous. It seems the more involved you are, the longer it takes to get everything working. But the worst part of it is really your penis kind of turns cold, it turns blue, it's not very inviting. And then you have to take the restriction band off. And truthfully, coming off the shaft of the penis is not bad, but going over the head of the penis hurts. And after about 4 months, I just gave it up. At that point, I did not know what else was available to cure ED. And for a year, I just became very, very, very emotionally distraught because I lost my manhood. I could not make love to my wife the way a man is supposed to be able to do that. Luckily, I did get an invite to a presentation like this and found out about these other, found out about these other treatment options. And my wife and I talked about it and decided to go with the implant. One thing I will say right off the bat, ED is not truly a male issue. It's a couple's issue. And I really believe that taking your spouse or your partner to the urologist that's going to do the implant or any of the ED treatments is really important. I get a lot of people who tell me my wife thinks I'm having an affair and I don't love her anymore and all of this. And that's the farthest from the truth. The problem is you can't, and there's no other reason. And this way you get your partner involved with what is actually happening to you. I had the surgery when I was 60 years old, 2 years after my prostate surgery. Had the implant done. I was home for 2 weeks, went back to work, went back to working out with the people at the gym that I work out with, showered with them. They have absolutely no idea there's anything inside me. People ask me about pain. I really did not have any really bad pain. They did send me home with good pain pills, but I was able to take a couple of Advils, and that took the edge off of everything. And that's what I stayed with, the Advils. After about 3-4 weeks, I went back to the doctor, and he showed me how to use the pump. And I went home, and for about a week, I would pump up and release and pump up and release. And you can get much more flaccid than what you saw in the video there by just holding the penis and just squeezing it. And you can get very flaccid. Also, my wife has said many times, had she not known me before the having intercourse with the implant, she couldn't tell there was anything different with me or anything inside me that wasn't natural. It looks totally natural. The only difference that I have ever found is that when you're 21 and you have an erection, you basically have an erection at a 45-degree angle from your body. And with the implant, you basically have an erection at 90 degrees. That's about it. The thing that's nice about it is it's with you all the time. All you have to do is reach down, and with a number of pumps, you have a solid, rigid erection, good for any type of intercourse or sexual play that you want to have. People ask me, well, does it interfere with urination or anything with the bladder? The answer is absolutely not. I have had 2 cystoscopies with the camera going up the urethra to look into my bladder. Doesn't interfere with that at all. Couple of things I will say. People ask me, well, when I go through the airport, does it go off under the metal detector? The answer is no. My knees go off because I have artificial knees. So they take me over to the side, and they take this stupid wand machine, and they take this wand and they run it up and down your body and inside your thigh and around your crotch. And the reality is it doesn't beep, it doesn't do anything, and they send you on your way. The thing that's nice about it the most is you don't have to worry about if you take injections, things like that. You have to keep the medication cold. You have to worry about keeping in the refrigerator when you go, on vacation, things like that. With the implant, it's there anytime you want it. Nobody can see it. And truthfully, it's probably the thing that basically was the second best thing I ever did in my whole life. I had my first implant for 14 years. 3 years ago, I had it replaced, and I'm 77. If I have it another 14 years and I'm still around, I'll have it replaced again. Simple as that. It is really that good. So, Dr. Goldenberg, I'll turn it back to you.